Thank you very much. I'd like to thank the organisers for inviting me and your presence. And it gives me great pleasure to raise awareness about antimalarial drug resistance because it's recently fallen off the radar. And I'd like to use this opportunity to make everyone aware that we actually need to start thinking again about antimalarial drug resistance because it's going to become a big problem if we don't actually start looking at it. And I've changed my topic slightly. I've expanded it rather to say Southern Africa because neither the parasite or the mosquito obeys any of the borders within the SADC region. So whatever actually happens in South Africa happens within the entire SADC region. But for the start, I'm going to actually focus primarily on South Africa and then expand it to the SADC region so you can understand where I'm coming from in terms of drug resistance. Okay, so let's just have a look at the current malaria risk in South Africa. It's limited to just the areas where we share borders with our SADC countries. So in Limpopo, it's the regions that we share a border with Botswana and Zimbabwe. In Mpumalanga, it's the Kruger National Park, where we share the nice border with Mozambique and Swaziland, and the northern regions of KwaZulu-Natal, where we share a border again with Swaziland and Mozambique. We've managed to push the malaria risk to these very border regions using two major interventions. One is vector control using indoor residual spraying, which is you go into the houses and you spray the inside of the houses with insecticide, and that theory is going to kill the mosquitoes. And then we've had a very effective case management program where we've made sure that you theoretically rapidly diagnose the malaria case and then you treat with an effective treatment. And I say in theory because I'm going to show you the malaria cases from 1973 to 2014. And as you can see, we've had very low incidence of malaria in the early 70s, and then it peaked in around about the 80s, and I'm going to use the pointer. Around about the 80s, that was associated with chloroquine resistance. Once it was detected, we changed our policy. We went into something that was known as Fansidar or sulfadoxine pyrimethamine. Our cases numbers dropped very nicely. We stopped surveillance because we thought, wow, malaria control is working really well. We also bowed to international pressure, and for indoor residual spraying, we stopped using DDT. We moved to pyrethroids. What happened was we had a two-pronged approach of resistance emerging. The mosquito became resistant to pyrethroids, as well as the parasite became resistant to Fansidar. And then we had a massive explosion of malaria cases. And in about the 1999-2000 malaria season, we had over 60,000 malaria cases reported in South Africa. And in that time, it was only in 2000, even when we had the 60,000 cases, did they actually begin to survey again and have a look to see what was happening. And then they detected the resistant parasite as well as the resistant mosquito. And South Africa then became the first country to introduce a combination drug, the first combination drug for malaria resistance, for malaria, which is known as Coartem. And I'm going to discuss it in a little detail further on. And they also reintroduced DDT for indoor residual spraying. And that had a major impact on our malaria incidence. And it dropped our cases really low to below the 10,000 level for quite a number of years. And then since about 2008, our malaria cases have dropped down to a normal level or a consistent level of below 10,000 cases. And we've had a national incidence of below 1 malaria case per 10,000 people at risk, which has allowed us now to enter what the WHO has defined as the elimination continuum. So South Africa, with other SADC countries, has now become one of the SADC eliminating 8 countries. And 4 of the countries, which are Namibia, South Africa, Botswana, and Swaziland, are theoretically going to eliminate malaria by 2020, with the next 4 countries going to do it by 2030. Which then raises the question, if we're going to eliminate, should we even bother about malaria or malaria antimalarial drug resistance? And I have 3 reasons why I definitely think we should. The first one is that there's been some modeling work done in Cambodia looking at it, and what they're finding is that as you get down to lower cases, what you're left with are the most resistant parasites. Secondly, having a look at what the mosquitoes do, the more resistant the parasite is, they have a higher uptake in the mosquito. So you've got a higher risk of getting, if you get bitten by a mosquito, you're going to get a resistant infection. So those are two important, but probably the most important factor is that artemisinin resistant, the dream drug that came along to say that was going to cure malaria forever, now has been detected in Southeast Asia. The more concerning thing is that despite major containment efforts being put in Southeast Asia, the drug-resistant parasites are spreading westwards. So the latest paper that's come up is actually now just reached the Myanmar, Indian border. So it is actually spreading really rapidly. Now, why is this of any concern to us? When when artemisinin combination therapy was recommended, based on, as we've heard in all the talks, both for HIV and TB. Using two to three more drugs with different targets is going to theoretically reduce the chance of resistance emerging. Artemisinins were fantastic. They rapidly reduced parasite loads. They also were active against the gametocytes, which are responsible with malaria transmission. I mean, artemisinins reduced parasite loads within 3 days. So they were the most dramatic acting drugs, and so they were so impressive that within 5 years of them being introduced, global use of ACTs is just now, ACTs, which are artemisinin-based combination therapies for malaria, are first-line treatment in every country in Asia and in Africa. Also, the most worrying thing, besides being first-line treatment, artemisinin-based combination therapies are also second-line treatments in all these countries. So you can imagine if we do get artemisinin resistance spreading, what would happen? Because this is both our first and second line. And artemisinin combination therapies are the last group of active drugs that we have for malaria treatment. If this goes, there is nothing on the market currently available to treat malaria. Okay, now, why is it more concerning about the Thai-Cambodia border? Because it is the historic epicenter of the emergence of drug resistance. The Thai-Cambodia border has been identified for all the antimalarial drug resistance that has happened for the past, since the 1950s. And I'm going to go through the two most important drugs, but I just want to show you how it works. It starts in the Thai-Cambodia border, and then it spreads outwards towards India. From India, then it spreads to Africa, and then through the rest. Okay, so let's start with chloroquine. Chloroquine was a drug, it was a synthetic derivative of quinine. It was developed in about the 1945s, was found to be incredibly effective against malaria. It was safe for use in children and pregnant women. So it became really widely used. It was an antipyretic, so it cured your symptoms really well, which also resulted in a lot of people not finishing the course. So it also contributed to the development of resistance. It was a mainstay of antimalarial drug treatment for over 50 years, but resistance emerged. And when they looked at the genetic markers for what was associated with the resistance, and they tracked it in Asia and in Africa, a most interesting pattern emerged. Again, the first signs of resistance occurred in the Thai-Cambodia border in 1957, and then it spread out through India, came into Africa, and sort of the center of the Horn of Africa seems to be the point, or Kenya, spreads down to the southern Africa, East Africa, and through the rest of Africa. Following this, there was a change in Southeast Asia and certain countries in Africa from chloroquine to something that is known as Fancida and sulfadoxine pyrimethamine resistance. I mean, sulfadoxine pyrimethamine. Okay, now, they thought they were quite wise. This time they were going to use a combination of two drugs, sulfadoxine and pyrimethamine. But it wasn't a combination therapy because they both attacked or interfered with enzymes in the same pathway. So they weren't affecting different targets. So obviously if resistance occurred to one, it was going to quite quickly occur to the other. It was quite safe in children and pregnant women. But the sad thing about this drug was that it had a therapeutic lifespan of about 10 years. Again, when they looked at the resistance patterns by looking at genetic markers of the drug failures, Believe it or not, it had exactly the same distribution plan as chloroquine, and this is around the 1990s. Again, started in Southeast Asia and spread eastwards and westwards, entered through Kenya and spread through to southern Africa. Another very interesting thing about sulfadoxine pyrimethamine resistance in southern Africa is that because chloroquine was still very cheap in comparison to SP, a lot of African countries didn't change to SP. They still used chloroquine, though it was a failing drug. But when we had a look through the SADC region, I'm just going to show you one of the studies that we conducted in Mozambique. Though Mozambique never ever changed to sulfadoxine pyrimethamine, we monitored the resistant markers that are associated with SP resistance. Then if you actually look in 2001, which was just about the same time that there was a major outbreak in South Africa, you can see the parasites in Mozambique were all carrying the markers associated with SP resistance, which gives you an idea that within the SADC region, that you actually can't look at one country and just be alone. You've just got to look at it as a global region and say that the whole SADC region is one country, because whatever's happening in one country is going to happen in the neighboring country. And then subsequently to the change to artemisinin drugs in South Africa, the presence of resistance parasites in Mozambique decreased to baseline levels again, all right, even though they never, ever had a policy of SP or anything to that effect. The question is, should we worry about artemisinin resistance in Africa since we're eliminating malaria? And again, my answer is going to be yes. We have an incredibly high artemisinin drug pressure across Africa, as we showed. The decreased transmission intensity in Africa is now very similar to Southeast Asia, which is making people think that since Southeast Asia was the historic epicenter of drug resistance, because of their low transmission intensity, because Africa is now replicating what used to be in Southeast Asia, we're probably going to be an epicenter of novel artemisinin resistance itself. We've got increased global travel, so people carrying resistant parasites from the east are most likely going to come to Africa at some stage, if they're not already here. And the other worrying thing about in Africa as well is that we've got a high use of counterfeit artemisinin drugs, which means people are being exposed to subtherapeutic levels of artemisinin. So we've got a very great risk. And the other thing about malaria parasites is that they develop a resistance really quickly to drugs. And all they do it is by doing a single point mutation in general, all right? And to give you an indication of how quickly and how widespread drug-resistant parasites are, wherever malaria is, there is an existence of a drug-resistant population, okay? So there's just no doubt that if there is antimalarial drug resistance to artemisinin in Southeast Asia, at some stage it's going to occur in Africa. So what are we going to do? And this is my call to everybody. Moving forward, we have to improve our health system. We've got to make sure that there's definitive diagnosis prior to treatment. You can't treat with artemisinin because you don't want to expose people that don't have malaria to the artemisinin drug. You've got to make sure there's good compliance. You've got to make sure that they get the right dosage. You've got to have regular assessment of drug efficacy. You've got to have a good surveillance system, and you've got to have a rapid response to resistance. Because if you let it spread, the mosquito spreads really can bite a number of people very quickly, so you can get an outbreak really rapidly. You've got to implement evidence-based interventions. Recently, in Africa, sadly, a lot of times an intervention is put in place or a drug is chosen without any evidence. So you've got to know whether there is background resistance, whether the drug is going to work or not before you implement it. And most importantly, we've got to make sure that there's regional harmonization, as we've shown in the SADC region. It's one country. So you've got to make sure that what is happening in Zimbabwe, for example, is exactly the same thing as happening in South Africa to make sure that happens. Thank you very much.